Today I'd like to talk about wonderful feature of new therapeutic endoscope coming from Fuji. It's really amazing endoscope which we can do aggressive procedure. Before that, I usually use standard therapeutic endoscope, but sometimes I had to stop my procedure because of the unable to access to the target lesion. But by using new therapeutic endoscope from Fuji, I can do everything now. So I would like to share some of my clinical experience. Well, this is my COI to disclose. One of the greatest feature of new therapeutic endoscope of Fuji is 160 degrees down undulation, which was almost impossible in the past. By using 160 down undulation, we can easily approach to difficult areas such as gastric fornix or the lesion behind the supraduodenal angle in the duodenum or the inferior duodenal angle. And of course, the duodenum is the most challenging part to do endoscopic resection, but by using new therapeutic endoscope, we can do it relatively smoothly, although it is still challenging. Well, and also new material makes it more easy to insert and give us more stable condition. And of course, we can control it very smoothly. And surprisingly, even for the small diameter, which is 7.9 millimeter outer diameter, has 3.2 millimeter working channel, and the image quality of this small diameter endoscope is really fantastic, and also it has water irrigation function, and of course it has 160 degrees down undulation.
Sorry, can we remark a little bit? So it's a 3.2 working channel in such a small scope.
Yes, that's right.
Wow.
It's a surprising situation.
And you have everything, water jet, you have everything on it.
Yes, everything we have. So by using this kind of new therapeutic endoscope, we can do everything now. This is one of the examples. This is extremely challenging recurrent esophageal cell cancer because this patient was treated by the previous doctor. Unfortunately, it caused the stricture formation. Therefore, previous doctor conducted multiple balloon dilatation, and unfortunately, perforation happened. And the stent was placed, and after healing the perforated area, again, it caused the stricture formation, but unfortunately, as you can see now, there was a local recurrence. It looks like invasive cancer already. But what we will do, we carefully check this lesion using BLI, but fortunately, there was no invasive sign. And after spraying iodine solution, the lesion size was around 3 centimeters. But at the middle of the recurrent lesion, there was really severe stricture formation, and of course, there was a severe fibrosis under the lesion. Unfortunately, standard therapeutic endoscope cannot pass through the stricture site. That's why we decided to do ESD using new outer stream therapeutic endoscope. By using this outer stream endoscope, we could approach to the anal side through the stricture side. And of course, there was a really severe scar formation. We conducted submucosal dissection by cutting directly through the scarred tissue. It was a really challenging situation, but fortunately, everything was completely removed in an unbroken fashion. And fortunately, there was no deep submucosal invasion. It was only M3 with high-grade intraepithelial neoplasia around the lesion, and we achieved almost curative resection in this particular case. Another example is the relatively tortured structure, relatively big lesion located at the tortuous area at the rectosigmoid junction.
To make sure everybody understands, relatively big for him is bigger than 10 centimeters.
No,
It's
I'm
not
sorry,
like for us.
it was not so big. But it was a really challenging situation because of the strong angulation and the tattooing below the lesion. That's why I decided to use the new therapeutic endoscope, which has 160 down angulation. So you can see the tattooed area here, and there was a really strong angulation at the rectosigmoid junction. So I attached the ST food from Fuji and immersed the entire lesion with the normal cell line and approach to the oral side at the beginning of the procedure, and injected a relatively large amount of glycerol solution to the submucosal layer to lift up the lesion. Especially at the angulated area, it was very much challenging even for me. Therefore, I carefully made an initial mucosal incision not to go deep to the submucosal layer. Soon after the initial mucosal incision, I traced the inner edge of the incised area using the dry knife and carefully conducted the submucosal dissection. Because of very strong angulation, it was really challenging, but by using the water pressure method, I could open the submucosal space and try to dissect the submucosal tissue very carefully and open the submucosal space gradually. And this was the really tortuous area. Therefore, I used the down angle maximally at the oral side of the target lesion and carefully hooked the edge of the submucosal tissue and conducted submucosal dissection. By the way, Fuji also developed a new narrowed band imaging, which is HCI, which is very effective to visualize the submucosal layer. Now you can see the bluish submucosal layer. This is standard white light image, so you can see the major difference. By using ACI, we can really see the clear blue color within the submucosal layer. After completing submucosal dissection at the oral side, I restarted the mucosal incision and submucosal dissection from the anal side in a straight position. Again, there was a severe angulation. Therefore, I carefully conducted the mucosal incision and submucosal dissection. And you can see some black ink within the submucosal layer, and there was some fibrosis, but still it was okay. I injected additional solutions through the knife and carefully conducted submucosal dissection. Even with the strong angulation, I could easily control the endoscope and easily conducted submucosal dissection without touching to the muscle layer. Now I completely resected the target tissue. As you can see here, there was tattooing also into the muscle layer, and there was a severe angulation. Fortunately, this was just a traditional threaded adenoma without having cancerous component. Therefore, we achieved curative resection. And the most challenging part is the duodenum. I really don't want to recommend you to do duodenal ESD because it's really challenging and risky procedure. And this is the target lesion. It looks like a not large lesion located at the second part of the duodenum, but reality was a little bit different. By using lateral viewing endoscopes, you can see the invasion to the diverticum just beside the major papilla. This is really challenging situation, but this patient was scheduled for Whipple's surgery. Unfortunately, this patient refused surgery because of the flat lesion, and the taken biopsy revealed just a high-grade adenoma. That's why this patient came to us. And we also hesitate to do endoscopic resection because of risky situation, but we found that it is possible to keep the retroflex position by using the outer slim new therapeutic endoscope. That's why we decided to do ESD also in this particular case. Of course, it was quite challenging. Initially, I approached to the anal side using the standard therapeutic endoscope, which is 840T. Oh, now you can see the diverticulum here. And the tumor was completely invading to the diverticula. So it was a really challenging situation. And again, I attached the ST food and approached to the anal side first in order to make sure the endpoint of the submucosal dissection. I injected a relatively large amount of glycerol solution and carefully dissected, made a mucosal incision and submucosal dissection at the anal side first in order to make sure the endpoint of the submucosal dissection. Maneuverability of the endoscope was a little bit poor, but still it was possible to do mucosal incision and submucosal dissection. Now I'm conducting a submucosal dissection using the water pressure method. I could easily open the submucosal space. Of course, it is quite challenging situation, but carefully conducted submucosal dissection from the both lateral side. And now I'm approaching to the diverticular side. You can see the invasion of the target tissue. I injected directly to the diverticulum. I used hyaluronic acid solution for the submucosal injection and switched to the TP, which has only 7.9 millimeter outer diameter. And approaching from the anal side in the retroflex position, I conducted submucosal dissection in a retroflex position. It was really challenging situation, but it was not so risky because I could visualize the submucosal tissue in a retroflex position. And finally, I tackled to the major papilla. Now I'm cutting through the major papilla using 1.5 millimeter dual knife. Now you can see the opening of the bile duct and cut through there and detach the major papilla from the duodenal wall. This is a really challenging situation, but still possible to do this kind of procedure if somebody has enough experience. Now, major papilla completely detached from the duodenal wall, and this is the final result. You can see the opening of the diverticulum, and of course, we introduced the transnasal drainage tube to both pancreatic duct and bile duct, and this is the specimen, and the resected specimen was 8 centimeter sized mucosal cancer, so we achieved curative resection and avoided unnecessary surgery. Well, as you have already seen, new therapeutic endoscope allow us to do more aggressive procedure in a safe manner, so we can perform new stage therapeutic endoscope with the new Fuji therapeutic endoscopy. Thank you very much for your kind attention.
For the people standing in the back, there are a couple of seats available here. You can come up and...
Lots of seats. Come forward, guys.
Take position here. Okay. So, beautiful. Everything beautiful. Stay here. Stay here. Professor Yagi, don't move. Don't move. Don't rush. He's going to do another ESD today, but just stay here. Don't move. So, we were making discussion lecture by lecture. We believe it's better. So, Pradeep, any question?
Well, yes. It's very interesting and exciting. The technology is looking very good. You highlighted two features. One was 7.9 millimeter diameter. Other one was 3.2 millimeter diameter. So in your view, the utility of this is in duodenum, in strictured areas, and tight sigmoid. Is there anything else?
I think the 7.9 millimeter outer slim endoscope is quite beneficial even for the POEM procedure because we can easily make a submucosal tunnel. And especially at the G junction, it works very well. For example, treating Barrett's case is quite good with the new therapeutic outer stream endoscope.
Questions from the audience? In the meantime, I have another question. I saw that you are doing most of your ESD underwater now, or under saline. So having such a bigger working channel is very helpful because the water exchange is much faster and very efficient. Is that correct?
Yes, that's right. It is one of the great features of new therapeutic endoscope. Previously, we could use only 2.8 millimeter working channel. Sometimes we cannot suck the liquid during the procedure. That was the problem, but now we can suck the liquid.
So it's another future.
Yes, that's right.
Torsten.
First of all, congratulations for the last case. It was amazing to see. As you mentioned, I think this is something that we, as endoscopists, we never had this in mind, that the down angulation makes such a difference, even for this new scope. So this is also our experience. In particular, for Barrett's lesions, we are very used to have Fujifilm scopes with very good upward angulation, but now the downward angulation makes a difference and makes it easier to approach the G junction, but also duodenum.
Yes, I completely agree with you.
And sometimes when you have a tough time with a sigmoid lesion or duodenal lesion, you need to retroflex. You want to make a very safe retroflexion. With 7.9, it's much safer. The scope is very slim and retroflex thanks to the bending angle very nicely, also in a tight space.
I just have a crazy idea while you are there. Stay there, because you are
Don't
one
move.
of HPB endoscopists. I saw in olden days, Torsten was probably young, we used to do direct cholangioscopy using slim gastroscope and get into the CBD. What you showed today, retroflex, open the CBD. If it's a dilated CBD about 10 millimeter,
you can get in.
Torsten, you would love to get in there with a 3.2 millimeter channel. Imagine the therapeutic capability.
This will be the topic for next year, the ESD in the
Okay, thank you so much.